Good morning. Thank you for having me today to discuss some very important issues regarding safety in patients with epilepsy. I have no conflicts of interest for this presentation. So how am I going to talk about this? I'm going to first talk about epilepsy-related injuries, then talk about epilepsy and driving, and then epilepsy and mortality accompanying it, and finally talk about what you want to hear the most, SUDEP, sudden unexpected death in epilepsy. So let's first talk about epilepsy-related injuries. What can the type of injuries be? One, you can have a submersion injury in the bath or in the pool. So we strongly recommend that you have shower stalls and not have tubs because you can drown in a tub. Burns, scald injuries, contact burns with radiators, hair dryers and irons. So we caution parents and caretakers to take notice of all these things and keep them away from the patient. Fractures are very important because the seizures themselves, the anti-seizure medications that they are given can reduce bone density and cause osteoporosis. And usually with the seizure, their extremities are involved with fractures because they are flailing around and the hands hit the railings of the bed or the wall and they get fractures. Head injuries, especially seen if you have drop attacks and if you have generalized tonic-clonic seizures. And we often put helmets on their heads as a precautionary measure to prevent these drop attacks because they can be pretty dramatic. I have seen children and adults just drop to the floor and have fractures on their skull because of this dramatic fall with a seizure. You can get soft tissue injuries. So for example, you can get facial injuries, tongue bites, cheek injuries, and even scalp injuries. Now, mind you, the tongue injuries usually happen on the side, the lateral side of the tongue, never at the tip of the tongue. And then you can get dental injuries involving the jaw and the teeth. Where are the sites where these injuries can happen? They can happen at home. They can happen at workplace if the patient with epilepsy is working. They can happen in the street, whether it's a child or an adult, and they can happen in a motor vehicle, whether the person is driving or is in the back of the car. So there are multiple places where the site of injury can happen in patients with epilepsy. The types of injuries can be accidental. Rarely can they be homicidal, where what is known as ictal violence. Ictal violence is extremely rare, where patients will attack somebody who comes near them, and that's defined as homicidal. And finally, many of the adult and teenage epilepsy patients can be suicidal because they also have comorbid anxiety and depression. So I think these are the types of injuries. Now, what are the risk factors? The risk factors for having these injuries is if the patient is also having substance abuse. He's using sedating medications, including anti-seizure medications, and especially benzodiazepines. He has an underlying ADHD, anxiety, or depression, or he has intellectual or cognitive deficits. These are some of the risk factors which can further worsen the risk for having injuries during seizures. A few words about epilepsy and driving. So, most states allow driving after 3 months to 1 year of being seizure-free. New York and New Jersey allow driving after 1 year of being seizure-free, though New York may allow driving 6 months when accompanied by a letter from the physician. 6 states mandate reporting by the physicians, these states are New Jersey, Pennsylvania, Delaware, California, Oregon, and Nevada. And fatal crashes from motor vehicle accidents in patients with epilepsy who are legally allowed to drive, that is about 57% of patients can legally drive, but fatal crashes in this population is extremely rare because they're legally allowed to drive, so the risks have been addressed. License to commercial vehicles is, on the other hand, 8 years of seizure freedoms because you want to be really safe, not only for yourself, but also for the people whom you're driving the vehicle for. So what are the favorable modifying factors that might lead to accepting a shorter seizure-free environment or requirement, or negating one completely? Include the following. If seizures occur during medically directed changes in medication, that means when you're changing one drug to the other and you have a breakthrough seizure, that's okay. If you have focal seizures without loss of awareness that does not interfere with consciousness or motor functions, that's still okay to drive. Seizures that begin with consistent and prolonged auras, because if you have an aura, you can pull over to the side and just, many patients have said, I take the key out of the car and I wait for me to completely recover before I start driving again. Seizures are related to acute toxic or metabolic states or illnesses that are not likely to recur on a consistent basis. And finally, seizures which happen only in sleep. So these are favorable risk factors. Now, what in contrast are unfavorable modifiers in which you may need to have a longer duration of seizure freedom before you can drive. Non-compliance with medications or medical visits or lack of credibility. Recent history of active alcohol or drug abuse. Structural brain disease, because they are more prone to have recurrent seizures. Uncorrectable brain functions, functional or metabolic disorders. Frequent seizure recurrences after prior seizure-free intervals. Prior crashes caused by seizures, and previous bad driving record. These are bad risk factors and may allow and may mandate that the physician and the DMV give a longer duration of seizure control. In general, non-compliance with driving regulations. So if harsher is the restriction, lower is the compliance. If there's less harsh restrictions, better is the compliance. That's just a standard rule. And 40 to 60% of patients with epilepsy who drive do not report their epilepsy to the authorities, which is not correct, because they really need to report. It's actually mandated that they report that they have epilepsy when they fill the forms on the driving license. So some facts which you need to know. We always educate about the risk for driving with seizures. We inform about the legal rules and responsibility for driving, including the duty to self-report. We explain, this is very important. We explain to the families that the decision as to when the patient can legally drive is not the medical providers, but it is that of the state legal authorities such as the DMV. Generally, medical providers make recommendations to that authority, but they are not making the decision. And we always document such decisions in the patient's medical record. So please don't drive if you're asked not to drive. It has a lot of culpable problems with insurance, legality, a lot of other issues are involved. Now, what are some jobs or careers with epilepsy or seizure-specific standards and restrictions? For example, if you have seizures, commercial driving is a little problematic. And there are different rules for different states and federal licensure. You cannot ever become a pilot for a commercial airline. You may be allowed a recreational pilot license, but it has a lot of restrictions. Bus drivers, same thing applies, that you may need 8 years at least in New York State. Military services, they have their own rules, because you don't want to be having problems outside the country where our country's reputation is involved. And finally, police and law enforcement officers, the rules vary by state to state. With restrictions with epilepsy, there are certain restrictions that go along with it. For example, as I mentioned about driving, many patients feel that their independence has been compromised. Employment is an issue. Many of the patients with epilepsy are not employed. They feel socially embarrassed. They feel that they're dependent on medications. Many of them have mood disorders and stress. Many of them have issues with respect to safety and injuries. The side effect of medications play an important role. Sexual dysfunction is quite common in patients, both men and women with epilepsy. Many of them are unable to get married. And most importantly, I have found the single most important factor is that patients with epilepsy and families with patients with children with epilepsy feel that they cannot predict what will happen this morning when I wake up. Am I going to be seizure free? Am I going to have a status epilepticus? Am I going to have clusters of seizures? That unpredictability is what drives them crazy the most. So epilepsy and mortality. And that brings us to what is SUDEP, sudden unexpected death in epilepsy. What is the definition? This is the 2012 definition of SUDEP. This is a modified definition. So definite SUDEP is when death happens in situations when it was not expected to happen, not with prolonged seizures or status epilepticus, and autopsy shows nothing significant. That is definite SUDEP. Definite SUDEP plus is when, besides that definition, you also have other identified factors. For example, there was a bronchopneumonia, or there was infections, or there was something else. So there is an additional factor, and that's why it is definite SUDEP plus. Probable SUDEP is same as definite, except that no autopsy was performed. Possible SUDEP is when a competing cause of death is clearly present. For example, status epilepticus. That is a clear, not a definite SUDEP condition. Near SUDEP is where somebody goes into the room and wakes up the patient, and the SUDEP risk is obliterated. So that's near SUDEP. And then not SUDEP is when clearly this is not because of SUDEP, but it's probably because of drowning or some other cause. And finally, unclassified, when you're not sure at all. So please pay attention to this modified NASHF criteria. In general, 1 in 40,000 people in the general population have a risk of suddenly dying, most oftentimes in their sleep, but sometimes in wakefulness. 1 in 1,000 patients, the risk in epilepsy patients is 1 in 1,000. The risk in refractory epilepsy patient is 1 in 200. And the risk in patients who need to be monitored in the epilepsy monitoring using unit, that means they're really the most refractory ones, is 1 in 100. So these are the general population risks. Now, this was a paper that was published in American Academy of Neurology, a practice guideline, but this was a 2016 paper, a 2017 paper. And in that, it said the risk in adults is 1 in 1,000, the risk in children is 1 in 4,500. So most pediatric neurologists and families thought, we are much better off than adults. I'm going to show you some additional data down the line. So what were the risk factors of SUDEP? If you had generalized tonic-clonic seizures, the odds ratio was 10. If you have very frequent tonic-clonic seizures, odds ratio was 5. If you were not seizure-free for the past 5 years, odds ratio was 5. If you were not taking anti-seizure medication in spite of having epilepsy, the risk was 6. Nocturnal supervision and risk of nocturnal listening devices were not found to be contributory in any way to prevent sorry about that. This was a nice paper that came about in the New England Journal of Medicine in 2010, a cohort of 240 patients who were followed in the Scandinavian countries over 40 years, and 24% of them died. But if you go back to why they died, 45 of those 60 patients had remote symptomatic cause of epilepsy, which went back many years before. And of these 40 of the 45 patients were not in remission. So the risk factor is if you have a long-standing epilepsy, usually due to some cause that happened in pediatric ages, and you were not seizure-free at the time of the event, you're at the highest risk of having SUDEP. But there could be other causes of death in epilepsy, and I have already discussed that, but these included pneumonia, cardiovascular disease, suicide, drowning, other causes. So sudden unexpected death, SUDEP, happened if the patient was not in remission from the seizures in the past 5 years. They had a prior history of status epilepticus. Age of onset was below 2 years of age. As I mentioned, remote symptomatic causes of epilepsy like meningitis, encephalitis, trauma, etc. in the pediatric ages. And there was a clear lesion on their MRI. Now, what could happen during SUDEP? It's basically believed to be a serotonin deficiency, and in the prone position with hypoventilation, that is shallow breathing during a seizure, and in lying with your head buried in the pillow, you have the highest risk of having SUDEP. So as I mentioned, almost 70 to 80% of patients with SUDEP die in their sleep at night. And almost all of them are found to be in the prone position with their head buried in the pillow, not able to breathe and suffocating. Also, the tonic phase, not the clonic phase, the tonic phase, that's what is at a high risk of having SUDEP because the larynx goes into a spasm. So can SUDEP occur in pediatrics? And the answer is here. So this is a U-shaped, bell-shaped curve. That means it can happen from below 10 years of age, and it can even happen in the geriatric population. And the risk of having these seizures is highest if your epilepsy begins below 10 years of age. The odds ratio is 8. If it begins at 30 years of age, the odds ratio is 4.6. So you can see earlier onset of epilepsy, higher risk of having SUDEP. So then two very revolutionary papers came out in the last few years. One came from the Scandinavian countries that the prevalence of SUDEP in children is 1 in 1,000, very similar to adults. A second paper came from Canada, very similar, 1 in 1,000 in children. So then the question becomes, why does this happen in pediatrics, and why was it missed in America? So we published a paper, an editorial on these two papers, and basically what we said was that the way the studies were done in these countries, which has nationalized healthcare, so that there's a homogeneous population of patients who can be properly looked at carefully, they did various statistical analysis, and that's how they got the data. So we now believe that the risk of having SUDEP in pediatrics is very similar to that in adults. And because of that, SUDEP North American registry was opened up. And this paper shows that when investigators interviewed the families of patients with epilepsy who had died, and what did they have one day before? What did they do? Some of them were non-compliant. They missed one dose. Some of them took alcohol. Many of them had sleep apnea and were not using CPAP. So there were a lot of risk factors, both in adults and children. And this paper gave a lot of new ideas which can be prevented in the future. So that's the next level. So can we prevent SUDEP? At this point, no study has so far shown that there are any specific measures which can reduce the risk of SUDEP. However, anticipatory guidance and counseling on SUDEP risk to families and adequate CPR training is mandatory. I always tell that to my families, that please get CPR certified. Aggressive management of refractory seizures is very important, because if you can reduce the seizure burden, you can definitely decrease the SUDEP risk, which can be by medications, by epilepsy surgery, by many other techniques. Ensure compliance of anti-seizure medications, avoiding sleep deprivation, and treat the underlying obstructive sleep apnea. 70% of patients with epilepsy have sleep apnea, and that can be fixed by CPAP or by other methods. Role of home monitoring, head high supine position, and nocturnal supervision at this point is unclear. So this is a paper which shows that if you can do good epilepsy surgery and decrease the seizure burden by making them seizure free, the risk of SUDEP drops dramatically. This is another paper which showed that there's a device called NeuroPace, responsive nerve stimulation, which detects seizures in the brain and gives an electric current to stop the seizure. If that is used correctly, the risk of SUDEP drops dramatically. Similarly, VNS, vagal nerve stimulation, if it's used correctly in appropriate patients, decreases the SUDEP risk and decreases the seizure burden also. And finally, we published a paper recently where we looked at the new drug fenfluramine, Fintepla, that's been approved for Dravet syndrome, which has a higher prevalence of SUDEP, that risk dropped tenfold by using fenfluramine in appropriate patients with Dravet syndrome. We also published a paper that if you have nocturnal seizures, why use 50% of the drug in the morning and 50% at night? Why not use 1/3 or 1/4 of the drug in the morning and 2/3, 3/4, or 3/4 of the drug at night? So what we showed here is that the seizure burden with a 50% in the morning and 50% of drug at night dropped to almost zero when we used 3/4 or 2/3 of the drug more at night. So now this is called differential dosing. A paper that came out from California showed that if you use SSRIs like Prozac, Paxil, Zoloft, can decrease morbidity accompanying seizures by improving oxygenation. So I definitely try using some of these drugs in patients who have periictal or around surrounding seizures, hypoxemia, and they turn pale or turn dark and stop breathing. Now, this is very important. Many of my patients have seizures in sleep. So I definitely advise them to buy this pillow, which is available on Amazon for $88. This pillow has these air columns, which basically allow you to breathe even if you are in the prone position, decreases asphyxiation and decreases the SUDEP risk. So definitely recommended. And then we have this Embrace 2 watch, which is like a Fitbit. You wear it and it detects seizures, and that data can be sent to the epileptologist over the phone so that you can do a seizure tracking, or you can do it manually on a day-to-day basis. And finally, there are some seizure dogs, but they're expensive. They're in the $25,000 range. They do detect generalized seizures. They don't detect absence seizures or partial seizures, which with just lack of awareness without any body movements. Seizure forecasting, that's the latest craze that's up there in epilepsy. This is based on artificial intelligence and big data mining. So can we predict having a seizure? Because if you can predict that tomorrow you're going to have a seizure, you can say tonight, get better sleep, don't drink alcohol, be CPAP compliant, don't miss doses, don't drive tomorrow, take an additional dose of medications. So all that can be done if you can predict that seizures are going to happen. So this is done especially like if you have seizure clusters that happen normally in people with epilepsy, some every 7 days, some every 28 days. That data is slowly coming out with the use of NeuroPace, which actually records seizures on a continuous basis. So you can actually do this prediction based on this multidian patterns. You can also do it based on interictal spikes that are often recorded during NeuroPace devices. And you can say, today I'm seeing clustering of spikes. That means you may have a seizure tomorrow. You can also do predictive forecasting if you can say, I think your seizures come only in the day, only at night, only in the afternoon. So based on these circadian patterns, you can also do predictive models. And finally, actually looking at the NeuroPace data that shows actual live EEG on a continuous basis, we often can say, I think you're going to go into a cluster tomorrow. So avoid doing crazy things tomorrow. So this is the future. This is where artificial intelligence, machine learning is going to tell us whether you can predict seizures next day, next month, that kind of a thing. Some practical points. You know, most people, epileptologists and neurologists feel, I don't want to discuss SUDEP. It's very traumatic for the families. So they avoid discussing it. But if you ask families, they feel, why didn't my epileptologist and neurologist not discuss that my kid, my family member can die in his sleep with SUDEP? So this discrepancy is very clearly there. This paper proves that point. And so why is this barrier there? So as I mentioned, the doctor's perception of what patients want. Is there enough time available during the clinic visit? Are other resources available for families to open up discussions? Cultural issues. When asked directly by families and patients, you should definitely discuss them. When concerned about compliance, you should definitely discuss that. When I sense there is an unaddressed fear, I definitely bring out this point. Is there some concern of SUDEP? And finally, as a general education. So this is a review article that I have published. Anybody who wants a copy can definitely email the EPIC, and we'll be happy to send you a copy of that. Now, I want to end before I say one important thing. New York State just recently in October passed a law, which says that the physician has to mandatorily discuss SUDEP with their patients with epilepsy during the clinic visit. So it's a big burden on us. It's a big task on us, but how are we coping up with that? So we have kept SUDEP educational material in the waiting room, SUDEP educational material in the actual office where in the examination room, and we bring up the point with the family as soon as we see them with epilepsy, because some papers are showing that even with a simple seizure, the risk of SUDEP is there. It's very negligible, but it is there. So we always now are mandated to discuss SUDEP risk with families as per the new New York State law that mandates that you document that in the EMR. And with that, I'm going to stop and will ask any questions that come up. Thank you so much for your attention.